This is red and white cell disorders. We'll start with the red blood cells and their different possible shapes. On a smear, normocytic cells are the same size as lymphocytes and should have an area of central pallor about 1/3 the total size of the cell. Spherocytes do not have this central pallor and are smaller than the lymphocytes when compared on a smear. Hereditary spherocytosis, an autosomal dominant condition, as well as immune-mediated destruction or thalassemia can lead to spherocyte development. A DAT or Coombs test can help determine if the process is more likely to be autoimmune versus hereditary spherocytosis. Spherocytosis will demonstrate a positive osmotic fragility test. Reticulocytes also lack central pallor but can be differentiated from spherocytes because they're not as small and they're polychromatophilic. If you see red blood cells that have purple dots inside, these could represent nucleated red blood cells or Howell-Jolly bodies, where the dot is more pinpoint. Both of these morphologies, nucleated red blood cells or Howell-Jolly bodies, suggest extramedullary hematopoiesis, functional asplenia, and/or marrow replacement, like with leukemia. Red blood cells that look mangled are called schistocytes, and they're present in cases of microangiopathic hemolytic anemia. On the bottom right, the smear shows thrombocytopenia, anemia, and schistocytes. This should make you think of HUS, especially if the patient has renal issues. When someone has large red blood cells, also called macrocytosis, or multiple lobes of the nucleus, which are called megaloblastic changes, consider B12 or folate deficiency. Heinz bodies that look like multiple Howell-Jolly bodies in one red blood cell represent aggregated hemoglobin. We see Heinz bodies when patients have unstable hemoglobinopathies like alpha thalassemia and G6PD deficiency. Bite cells are produced when the spleen removes the Heinz bodies. Basophilic stippling is also shown on this slide. This occurs with iron deficiency and with lead poisoning. Microcytosis, defined as an MCV less than 70, and/or hypochromasia, is seen with iron deficiency, lead toxicity, thalassemia, and anemia of chronic inflammation. When iron is supplemented, we expect to see increased reticulocyte count by 1 week, increased hemoglobin by 2 to 3 weeks, and increased ferritin after 3 months. When patients have pyruvate kinase deficiency, their red blood cell structure is unstable, leading to hemolysis. A byproduct called 2,3-DPG accumulates and shifts the oxygen dissociation curve to the right, so that even though these patients are anemic, they have some exercise tolerance, surprisingly. Now we'll discuss platelet morphologies. Newly produced platelets are larger than old platelets, which shrink over time. So in a consumptive state like ITP, there are more new and giant platelets and higher coagulability. Which of the following will increase iron absorption in the small intestine? Vitamin C, oxalate, lysine, fructose, or citric acid? The correct answer is the oxalate. What is the best parameter to determine adequate iron replacement therapy? Improvement of anemia, decreased TIBC, increase in ferritin, appearance of reticulocytes, or rise in free erythrocyte protoporphyrin? The correct answer is increase in ferritin. With lead toxicity, the overlap with iron deficiency is important. Patients with iron deficiency often develop lead toxicity from the subsequent pica. Their red blood cells show basophilic stippling and increased free erythrocyte protoporphyrin. This occurs because lead inhibits heme synthase from converting protoporphyrin into heme. Because of the association with iron deficiency, lead poisoning is associated with microcytic anemia. Long bone x-rays may show lead lines. Lead screening is done at 1 year and at 2 years, or at 3 to 6 years if it was never done previously. Positive tests require a venous sample for confirmation, and 45 or higher is the cutoff to consider chelation therapy. We use EDTA, dimercaprol, or D-penicillamine. A 2-year-old boy has a capillary lead level of 25 on a routine visit for his well child visit. He's otherwise healthy with no symptoms. His exam is normal. What is the next best immediate step in management? Begin oral chelation therapy, hospitalize, obtain abdominal radiographs, perform a home investigation, repeat lead level with a venous sample. The correct answer is repeat the lead level with a venous sample. To recap, a lead level less than 2 is normal. A lead level 2 to 5 needs to be trended every 6 months. A level of 5 or greater requires investigation with public health, and greater than 45 requires chelation. For these questions, you would answer whether the association is with iron deficiency, lead toxicity, both, or neither. Hypochromic and microcytic anemia. That's associated with both, but stems from the iron deficiency itself. Acute encephalopathy. That's associated with lead toxicity. Elevated free erythrocyte protoporphyrin. That's related to both pathologies. More common in children of low-income families. That's also related to both pathologies. Which combination of globin chains is present in hemoglobin F? Alpha 2, delta 2, gamma 4, alpha 2, beta 2, alpha 2, gamma 2, or none of the above? The correct answer is that hemoglobin F is alpha 2, gamma 2. Delving deeper into the red blood cell, now we'll discuss hemoglobin morphologies. Hemoglobin needs 2 alpha and 2 non-alpha chains to function. Fetal hemoglobin F has 2 alpha and 2 gamma chains. Most adult hemoglobin is hemoglobin A, which has 2 alpha and 2 beta chains. 2% of adults have hemoglobin A2, which has 2 alpha and 2 delta chains. When patients have alpha thalassemia, this means they're unable to make alpha chains. Providers might be suspicious for alpha thalassemia in a patient with microcytic anemia that's not responding to iron supplementation. Hemoglobin will be unstable depending on how many genes are affected, with variable degrees of hemolysis and jaundice. With one defective gene, patients can be silent or asymptomatic carriers only. With 2 defective genes, patients have alpha thalassemia trait with a mild anemia. With 3 defective genes, patients make hemoglobin with 4 beta chains, which is called hemoglobin H. They have a moderate hemolytic anemia and jaundice that's around the 6-month mark when the fetal hemoglobin is decreasing. With 4 defective genes, patients make a hemoglobin with 4 gamma chains. This is called hemoglobin Bart's and is fatal from hydrops fetalis as a neonate. A patient is found to have the majority of their hemoglobin as hemoglobin Bart's. How many alpha globin genes were defective in this patient? 0, 1, 2, 3, or 4? The correct answer is 4. When patients have beta thalassemia, they cannot make beta chains. Remember, fetal hemoglobin F has 2 alpha and 2 gamma chains. So not being able to make beta chains is not a problem until the infant starts transitioning to the adult hemoglobin A around 6 months. Remember, hemoglobin A needs 2 alpha and 2 beta chains. So these patients with beta thalassemia have higher numbers of hemoglobin F and hemoglobin A2. Hemoglobin A2 was 2 alpha and 2 delta. If defective beta synthesis leads to the production of hemoglobin with 4 alphas instead, these are so unstable that they don't leave the bone marrow. This can cause hepatosplenomegaly, which is an important association for beta thalassemia. Patients with beta thalassemia minor have a mild microcytic anemia. Beta thalassemia intermedia is moderate, and beta thalassemia major is transfusion dependent. Beta thalassemia major also has some unique clinical features. We talked about hepatosplenomegaly. They also have thinning cortices and dilated marrow cavities in the long bones, a hair on end appearance in the skull bones, frontal bossing, protrusive maxilla or the chipmunk face, and liver, heart, and kidney failure. They often are treated with defuroxamine to manage iron elevation from hemolysis as well. On a smear, they will have microcytosis and target cells. Here's a classic vignette for beta thalassemia. A 2-year-old Italian presents with hepatosplenomegaly and has mild microcytic hypochromic anemia. For this rapid-fire association question, the answer choice will either be alpha thalassemia or beta thalassemia. Which has the association with Black patients? This is alpha thalassemia. Which is associated with Mediterranean patients? This is beta thalassemia. Which is associated with Southeast Asian patients? This is alpha thalassemia. Which one is noted from newborn onward? This is alpha thalassemia. Which one is symptomatic after 6 months? Beta thalassemia. Which is more associated with jaundice and hemolysis? Alpha thalassemia. Which is associated with hepatosplenomegaly? Beta thalassemia. Which is associated with production of hemoglobin H? That's alpha thalassemia. Which is associated with a hair on end skull X-ray? Beta thalassemia. Which is associated with production of hemoglobin Barts? That's alpha thalassemia. What about hydrops fetalis? Alpha thalassemia. Which is associated with increased production of alpha 2 and hemoglobin F? That's beta thalassemia. And then finally, which is associated with the chipmunk face? That's beta thalassemia. Which of the following is most likely to be present in a patient with hemoglobin H disease? Macrocytic anemia, elevated bilirubin, elevated hemoglobin A2, increased TIBC, or positive DAT? The correct answer is elevated bilirubin. Which of the following is most closely associated with beta thalassemia minor? Onset in the newborn period, more common in patients of Northern European background, hepatosplenomegaly, jaundice, or growth failure? The correct answer is hepatosplenomegaly. For these rapid-fire associations, answer whether it's associated with alpha thalassemia, beta, both, or neither. Ineffective erythropoiesis. That's associated with beta thalassemia. Severity of disease being proportional to the number of defective genes. That's alpha thalassemia. Production of hemoglobin H. That's alpha thalassemia. Production of hemoglobin A2 and F. That's beta thalassemia. Diagnosis in the newborn period. That's alpha thalassemia. An iron-responsive microcytic anemia. That's neither. Errors in the transcription or translation of globin mRNA. That's beta thalassemia. A few disease processes can cause normocytic anemia without affecting red blood cell morphology. Physiologic anemia of infancy describes the nadir that occurs around 2 to 3 months below a hemoglobin of 13. This can be earlier and with a lower nadir in premature infants. Non-immune hemolytic anemias like hereditary spherocytosis or elliptocytosis, like G6PD deficiency, or like sickle cell can be normocytic. Immune-mediated hemolytic anemias like microangiopathic hemolytic anemia, HUS, autoimmune ABO or DAT-positive anemia, those can also be normocytic. This is also true for anemia related to chronic inflammation, aplastic anemia and leukemia, and transient erythroblastopenia of childhood. A 12-week-old full-term infant of Mediterranean descent is referred to you for anemia. He has an unremarkable birth history. The child has been exclusively breastfed since birth. Physical exam is unremarkable. Hemoglobin is 11.4, MCV is 90. The most likely cause of the anemia is alpha thalassemia trait, G6PD deficiency, beta thalassemia trait or beta thalassemia minor, iron deficiency, or physiologic anemia of infancy. The correct answer is physiologic anemia of infancy. A 4-year-old boy in the emergency room has a history of fever, upper respiratory infection, and skin rash 3 weeks ago, followed by gradually increasing fatigue 1 week ago. He had jaundice as a neonate. His family history is positive for the same condition in his father, who had a splenectomy. The boy is jaundiced, has mild splenomegaly. His CBC shows hemoglobin of 5.2 with a normal MCV. He has a normal white blood cell count and platelet count. He has many spherocytes and he has increased polychromasia. LDH and bilirubin are elevated. This condition is most commonly associated with positive DAT, only male family members are affected, loss of splenic function by 8 to 10 years of age, aggravation by the parvovirus B19 infection, diagnosed by genetic testing. The correct answer is aggravation by parvo. This patient has hereditary spherocytosis. This is an autosomal dominant hemolytic anemia. It may present intermittently and can be associated with jaundice and splenomegaly. Buzzwords include the abnormal band 3 and spectrin or ankyrin proteins, and this disease can be diagnosed with osmotic fragility testing. The morphology of the red blood cells are hyperchromic, microcytic, and with a high MCHC. There should be anemia and a low reticulocyte count. Parvovirus infection can cause aplastic crisis. Diagnose this with IgM titers. HS is often treated with folic acid, transfusions, and splenectomy if needed. If a patient presents with dark urine in the morning, they may have paroxysmal nocturnal hemoglobinuria. This is a complement-mediated hemolysis. It's autoimmune, but Coombs will be negative because it involves complement instead of antibodies. Diagnosis is with CD59 flow cytometry, DFA, or Ham's test, which tests fragility with acetic acid exposure. Hereditary spherocytosis is characterized by all the following except autosomal dominant inheritance. It's caused by a defect in the major supporting protein of the red blood cell membrane. Loss of membrane fragments leads to formation of spherocytes. Macrocytic anemia. Diagnosis made by osmotic fragility tests or flow cytometry for EMA. The correct answer is macrocytic anemia. Macrocytic anemia did not apply to hereditary spherocytosis because hereditary spherocytosis is a microcytic anemia. In which disorder would you most likely see Heinz bodies on a peripheral smear? Sickle cell disease, beta thalassemia major, G6PD deficiency, HUS, or hereditary spherocytosis? The correct answer is G6PD deficiency. A previously healthy 5-year-old boy develops dark Coca-Cola discoloration of urine over 24 hours with increasing pallor and lethargy. This patient might make you think of glomerulonephritis, maybe paroxysmal nocturnal hemoglobinuria if it was only in the morning, or of G6PD deficiency. G6PD deficiency is an X-linked disease causing boys to have a normocytic anemia, neonatal jaundice, and acute hemolysis with triggers like Bactrim, Cipro, Macrobid, malaria medications, or favamines. In addition to the normocytic anemia, patients have increased reticulocytes, decreased serum haptoglobin, and increased urine hemosiderin with the hemoglobinuria. A 2-year-old girl presents with 1 day of painful swelling over the hands and feet and low-grade fever. Her slide is shown below. This patient has sickle cell anemia. The mutation to remember that causes this disease is glutamic acid to valine on the beta globin chain. Because of the presence of fetal hemoglobin, there's usually no issues before 6 months. But when hemoglobin F transitions to hemoglobin S predominantly, issues arise. Sickle cell anemia usually causes dactylitis as the first symptom before age 5. Patients with a diagnosis of sickle cell disease should receive penicillin prophylaxis through the age of 5. On a newborn screen, a normal hemoglobin profile is Fa, which will turn into hemoglobin A only as an adult. If someone has FSA, they have sickle cell trait, which will turn into SA as an adult. If a baby has FSS, this is sickle cell anemia and will become SS as an adult. If someone has FSA, so high predominance of FS and A as an adult, it suggests sickle cell trait with beta thalassemia. When sickle cell patients have infections, the opportunistic infections for them are pneumococcus, salmonella for osteomyelitis, and H. flu if they're asplenic. Patients in crises should only receive transfusions if there's anemia and crisis occurring. IV hydration can improve the crisis process conversely. With acute chest syndrome, transfusion is important for breaking the sickling cycle. Hypostheneria indicates renal damage causing dilute urine with a low specific gravity, so patients might falsely appear euhydrated on their UA. For suspected stroke, MRI is the best imaging modality. Which finding on a peripheral smear is most indicative of loss of splenic function in sickle cell disease? Nucleated red blood cells, spherocytes, basophilic stippling, polychromatophilic red blood cells, or schistocytes? The correct answer is nucleated red blood cells. An 8-month-old is most likely to manifest this complication of sickle cell disease: priapism, stroke, acute chest syndrome, hypostheneria, dactylitis. The correct answer is dactylitis. When giving transfusions, it's important to be on alert for hypocalcemia, hyperkalemia, and thrombocytopenia as complications. The standard PRBC transfusion volume is 10 to 20 milliliters per kilogram. Hemolytic uremic syndrome, or HUS, is a type of microangiopathic hemolytic anemia seen in young children. It's associated with a preceding colitis or bloody diarrhea, schistocytes, thrombocytopenia, and renal failure. A 6-year-old girl has an acute onset of abdominal pain and dark urine. Her exam is remarkable for tachycardia, pallor, and sclera icterus. Her abdomen is diffusely tender and her spleen is 3 centimeters below the left costal margin. Her hemoglobin is 5, white blood cell count is 12.5, platelets are 180,000, and retic is 6.5%. Renal labs are normal. Which test is most likely to confirm the diagnosis? Abdominal ultrasound, bone marrow aspirate, complement level, DAT, or stool for occult blood? The correct answer is DAT. This girl has autoimmune hemolytic anemia marked by rapid onset and severe anemia. Patients will have pallor, fatigue, jaundice, splenomegaly, and dark urine. These patients are DAT positive. Autoimmune hemolytic anemia can be related to lupus, malignancy, immunodeficiency, and Evans syndrome, but autoimmune hemolytic anemia can also be idiopathic. A 6-week-old term baby girl is referred for anemia. The maternal blood type is O positive and the baby's blood type is A negative. Cord blood shows DAP positive and hemoglobin of 14.3. Phototherapy is started at 48 hours of life for a total BILI of 15. She's discharged on day of life 5. Today she looks pale. Her hemoglobin is 8.5 and her total BILI is 3.5. The peripheral smear has spherocytes. What is the most likely current explanation for the anemia? ABO incompatibility, G6PD deficiency, hereditary spherocytosis, physiologic anemia of infancy, or Rh hemolytic disease? The correct answer is ABO incompatibility. With ABO incompatibility, look for the setup with the mother's blood type being O and the infant's being A or B. Maternal antibodies against A or B, since she doesn't have those antigens, can persist for up to 3 months. Look for spherocytes from antibodies destroying the red blood cells in the liver and spleen. This is called extravascular hemolysis. With extravascular hemolysis, IgG antibodies and macrophages digest cells in the liver and spleen, causing spherocyte formation from the mechanical stress. Spherocytes are seen with hereditary spherocytosis, hemolytic disease of the newborn, and autoimmune hemolytic anemia. Destructive hemolysis also contributes to indirect hyperbilirubinemia. Intravascular hemolysis occurs when IgM and complement work together to lyse cells directly. This is seen with HUS, G6PD, and Cassabauck-Merritt syndrome. These patients will have free hemoglobinemia and hemoglobinuria, decreased haptoglobin, and schistocytes. If hemolysis is an autoimmune-mediated process, the Coombs test will be positive. A direct Coombs test mixes the patient's red blood cells with anti-antibody antibodies. If they attach, then the hemolysis is immune-mediated. An indirect Coombs test mixes the patient's red blood cells with similar but alien red blood cells. If the alien red blood cells lyse, there was antibody present in the patient's blood. So the direct Coombs directly detects the patient's antibodies, and the indirect Coombs uses a red blood cell transfusion to bait the patient's antibodies. A 5-year-old ventilator-dependent boy is on IV antibiotics for Pseudomonas tracheitis. He's afebrile and at his baseline respiratory status. He has a persistent purulent exudate with elevated CRP. He has persistent anemia on enteral iron with a hemoglobin of 9, MCV of 65, and a low serum iron. The most appropriate next step is stop iron and continue treating his infection, give parenteral iron, add B12 and folate, or send hemoglobin electrophoresis. The correct answer is to stop iron and continue treating his infection. This patient has anemia of chronic disease. This is usually normocytic but can be microcytic. Patients have a low serum iron, low TIBC, but high ferritin from sequestration. They did not respond to iron supplementation. There's also a lower EPO than appropriate for the degree of anemia. If anemia is macrocytic and megaloblastic, consider B12 or folate deficiency. Megaloblastic means that the cells have multiple lobes or are hypersegmented. The buzzwords of a diet containing goat's milk, which is low in folate and iron, and a vegan diet go along with macrocytic anemia. B12 deficiency can also be from poor absorption in the ileum. Unique features of folate deficiency that can help differentiate clinically from B12 are the neural tube defects and glossitis with folate deficiency. Macrocytic anemia without megaloblastic cells is also seen in bone marrow failure syndrome such as Diamond-Blackfan anemia, Fanconi anemia, and aplastic anemia. For this rapid-fire association set, answer whether the association is with folate deficiency, B12 deficiency, both, or neither. Hypersegmented polys, that's associated with both. Poor diet, pregnancy, and chronic hemolysis, that's associated with folate. Ileal resection, that's associated with B12 deficiency. Normocytic with a low reticulocyte count, that's neither. Tapeworm, that's B12. A vegan diet, that's B12. To recap and summarize the anemia subtypes, microcytic and hypochromic anemia might be related to iron deficiency, lead toxicity, thalassemia, or chronic inflammation. Normocytic anemia might be from physiologic anemia of infancy, hemolytic anemia, chronic inflammation, aplastic anemia and leukemia, or transient erythroblastopenia of childhood. Transient erythroblastopenia of childhood typically has an onset around age 2. That's a gradual onset. It's benign and self-limited. Macrocytic and megaloblastic anemia can be from B12 or folate deficiency. Macrocytic anemia without megaloblasts can reflect marrow failure. This section will cover the hypoplastic anemias related to bone marrow failure. In order from youngest age at presentation to oldest, the three main hypoplastic anemias are Diamond-Blackfan in infants, TEC in toddlers, and Fanconi in older children. As mentioned previously, Diamond-Blackfan anemia is a macrocytic anemia without megaloblastic cells. It presents in infancy and is associated with short stature and triphalangeal thumbs. They will show high EPO and high RBC adenosine deaminase or ADA enzyme concentration. The marrow is not responding properly to the appropriately high EPO, and the ADA enzyme is needed for the high turnover associated with salvage of inadequate red blood cells that the marrow is making. Transient erythroblastopenia of childhood is kind of like the ITP of red blood cells. ITP was when a transient stress like an illness prompted platelet destruction. TEC commonly occurs in toddlers with infections and causes a normocytic anemia with spontaneous recovery. With Fanconi aplastic anemia, there's a constellation in the phenotype that can help you differentiate it. Fanconi aplastic anemia is associated with short stature, café au lait spots, renal abnormalities, microcephaly, micrognathia, upper limb abnormalities, a broad nasal bridge, and epicanthal folds. Chromosomal breakage studies can be diagnostic because Fanconi aplastic anemia results from defects in DNA repair. Patients with Fanconi anemia are at increased risk for leukemia and other cancers and need a bone marrow transplant for a curative therapy. With all of the aplastic anemias from bone marrow suppression or failure, look for many penias, many cell lines down, and no jaundice to suggest hemolysis. We might have neutropenia, thrombocytopenia, reticulocytopenia, and anemia. Aplastic anemia can be macrocytic, like in Fanconi anemia, or normocytic in patients undergoing aplastic crises. Aplastic crises can be triggered by chloramphenicol and by parvovirus in patients with sickle cell disease or hereditary spherocytosis. To differentiate aplastic anemia from leukemia, leukemia also has lymphadenopathy, hepatomegaly, and high LDH and uric acid. These features of leukemia are not typical of aplastic anemia. When neutrophils are deficient or defective, immunodeficiency results. If they're defective, the ANC might be normal, but the patient is still getting chronic bacterial infections. This applies to chronic granulomatous disease. Patients have recurrent purulent fungal and bacterial infections in the skin, lungs, and gut because of a respiratory burst defect. Chronic granulomatous disease is diagnosed with the dihydrorhodamine test or the less accurate NitroBlue test. CGD patients are particularly susceptible to the catalase-positive organisms. These are Staph aureus, Pseudomonas, Klebsiella, E. coli, Serratia, Candida, and Aspergillus. The diagnosis of neutropenia is considered mild for 1,000 to 1,500, moderate for 500 to 1,000, and severe for less than 500. Agranulocytosis applies to an ANC less than 100. For diseases causing neutropenia, this section is also in order from youngest to oldest. Costman syndrome, or severe congenital neutropenia, presents in an infant with severe infections like omphalitis, stomatitis, perirectal abscess, and pneumonia. The ANC is usually less than 200 for Costman, or also called severe congenital neutropenia. Gram-CSF can be provided to decrease infection risk for these patients. Long-term, these patients have an increased risk for AML. Chronic benign neutropenia is like the ITP for neutrophils. It's autoimmune and usually resolves by age 2. Cyclic neutropenia is an autosomal dominant disorder where patients decrease their ANC below 200 every 2 to 4 weeks. Checking a CBC weekly over 6 to 8 weeks can catch this trend. During the neutropenic periods, patients with cyclic neutropenia are susceptible to severe infections, especially Clostridium for cyclic neutropenia. Another buzzword for cyclic neutropenia is the presence of oral lesions. These patients can also receive Gram-CSF to reduce infection risk during their naders. An 18-month-old Caucasian girl has an ANC of 150 on a routine CBC with normal white blood cell morphology. The remainder of her CBC is normal. Her exam and developmental milestones are normal. She had a febrile illness 2 weeks ago but has otherwise been doing well without increased infections. Consider the following differential for this patient. She might have transient or infection-associated suppression. She may have chronic benign neutropenia, also called primary autoimmune neutropenia, or she might have cyclic neutropenia. So you might consider repeating the CBC in 4 to 6 weeks or checking it twice weekly for 6 to 8 weeks. You should have her follow up sooner though if she has any evidence of illness or increased fatigue. An 18-month-old girl is brought in for a pale appearance. She's previously healthy. She had an upper respiratory infection 1 week ago. She's tolerating a regular diet and is alert and active. Her exam is unremarkable except for her pale appearance. The CBC shows a normal white blood cell count and platelet count. Her hemoglobin is 4.5 with an MCV of 74. The most likely diagnosis is severe aplastic anemia, Diamond-Blackfan anemia, iron deficiency anemia, Fanconi anemia, or TEC. The correct answer is TEC. A 2-month-old girl is brought in for pale appearance. Her CBC shows a normal white blood cell count and platelet count, but a hemoglobin of 5.5 and MCV of 105. The most likely diagnosis is severe aplastic anemia, Diamond-Blackfan anemia, iron deficiency anemia, Fanconi anemia, or TEC. The correct answer is Diamond-Blackfan anemia. A 3-year-old girl is well below the 5th percentile for her height and weight. Her past medical history is unremarkable. Her exam shows micrognathia, hypoplastic thumbs, and areas of hyperpigmentation on her chest and thighs. Her CBC is normal. The most likely diagnosis is paroxysmal nocturnal hemoglobinuria, thrombocytopenia absent radii syndrome, Diamond-Blackfan anemia, myelodysplastic syndrome, or Fanconi anemia. The correct answer is Fanconi anemia, which is associated with older children than toddlers, cafe au lait spots, short stature, and hypoplastic thumbs. For this girl with Fanconi anemia, the most useful diagnostic test is bone marrow aspirate and biopsy, CBC, red blood cell ADA, DEB-induced chromosome breakage study, or dihydrorhodamine reduction test. The correct answer is the chromosome breakage study. This slide will do some broad pattern recognition with vignettes. So try to guess the answer before the end of the vignette. A previously normal 5-year-old boy has dark Coca-Cola colored discoloration of his urine over 24 hours. This is X-linked G6PD deficiency. An 8-year-old girl who's Caucasian has repeated episodes of pallor and jaundice and a positive family history of anemia and splenectomy. This is hereditary spherocytosis. A 4-year-old Vietnamese boy has a microcytic hypochromic anemia and no response to iron. This patient likely has alpha thalassemia. A 2-month-old girl has pallor and increasing lethargy, a hemoglobin of 4, an MCV of 115, and a reticulocyte count of 0. She has Diamond-Blackfan anemia. A 3-day-old has omphalitis, an ANC of 100, a normal hemoglobin and platelet count. This patient has severe congenital neutropenia. A 9-year-old has a hemoglobin of 9, an MCV of 95, a platelet count of 100,000, and an ANC of 1250. The height is below the 5th percentile. This patient has Fanconi anemia. You're following a 5-year-old male who's been hospitalized for a second episode of Staph aureus sepsis. He has an inguinal lymph node which was previously excised due to recurrent lymphadenitis, which the parents were told was due to a fungal infection. What test would likely confirm his diagnosis? CH50, BTK expression by flow cytometry, WAS protein level, dihydrorhodamine assay, or B cell counts? The correct answer is dihydrorhodamine assay. This patient has chronic granulomatous disease with their recurrent bacterial and fungal infections. A 5-year-old boy presents with a 3-day history of URI symptoms, fever, and diarrhea. On exam, he's mildly dehydrated with scleral icterus and hepatosplenomegaly. His CBC shows a hemoglobin of 11 and hematocrit of 30, white blood cell count of 10.5, and a normal differential. He's had prior episodes of jaundice as well as a history of neonatal jaundice. His father and older brother have also developed transient jaundice after viral illnesses. The most useful diagnostic test is serum iron, reticulocyte count, a Coombs test, an EMA binding test or eosin 5' malamide binding test. This is flow cytometry, or hemoglobin electrophoresis. The correct answer is the EMA test for hereditary spherocytosis. A 6-year-old boy is being treated for osteomyelitis. He was noted to develop a microcytic anemia with a low serum iron and low iron binding capacity. Despite a 2-week trial of therapeutic iron, there's been no improvement in his hemoglobin. The most useful additional laboratory test would be reticulocyte count, ferritin, CRP, serum haptoglobin, hemoglobin electrophoresis. The correct answer is a ferritin. This patient has anemia of chronic inflammation from their osteomyelitis infection. A 20-month-old girl presents with a right cervical adenitis. Her white count is 7.2 with normal morphology, but with an ANC of 70. CBC and platelet count were normal, and the patient was afebrile and otherwise doing well without lymphadenopathy or hepatosplenomegaly. The remainder of her exam was unremarkable. She had a good response to antibiotics. Subsequent CBCs done 2 or 3 times a week over the next month show ANC to vary randomly between 50 and 300. Since starting daycare, she's had constant URI symptoms but without fevers. She has no history of invasive bacterial or fungal infections. The most likely explanation for this scenario is autoimmune neutropenia, early aplastic anemia, Kostman's neutropenia, cyclic neutropenia, or Evans syndrome. The correct answer is autoimmune neutropenia. This is also called chronic benign neutropenia. If this girl had cyclic neutropenia, she would have more oscillation of her ANC. And if she had congenital neutropenia or Kostman's neutropenia, she would have more serious infections. And then the last question. A 2-year-old girl has a petechial rash for 1 day. She's afebrile with a normal appetite and activity and otherwise is well. She has no mucosal bleeding. There are scattered bruises over both shins but no other bruises, and there's no organomegaly or lymphadenopathy. CBC is normal with normal morphology and differential. Platelets are decreased to 8,000 and are large. The most appropriate initial management would be bone marrow examination, prednisone, observation, IVIG, or follow the daily CBCs. The correct answer is observation. This patient has ITP without active bleeding, so she can just be observed for likely self-resolution. And that is the end of red and white cell disorders.